mute, right? I'll unmute. So we've reduced mortality by half, but we've tripled the number of patients going to rehab. And so with that, the overall healthcare costs for these patients exceed about $41 billion annually. So patients in the ICU, kind of all comers, MICU, SICU, if you stay in the ICU for greater than 14 days, that particular patient population is pretty expensive, all the rehab and things like that. So the way I like to think about this is we do an excellent job at getting these patients to live through their critical illness, but we're failing to help them survive. And so what do these ICU survivors look like, right? We know this. We know what in the SICU in particular. So we've got them laying in bed for weeks. You know, initially they're super sick. You don't even want to turn them sometimes. You've got all the tubes and lines and things like that. So it's no wonder they develop ICU-acquired weakness and neuropathy. We strap them down. We sedate them on medications. We don't let them sleep. And we've got alarms going off 24/7, right? And so I know if I have a 24-hour shift in the ICU or longer, I even come home at the end of the day and I can physically hear the alarms in my head. So if you can imagine staying there for 30 days straight, not really sleeping, heavily medicated, delirious, it's no wonder these patients get pretty significant anxiety and depression. They get pretty bad PTSD just from being in the ICU. They've got long-term sleep problems and long-term neurocognitive issues. And so this kind of constellation of symptoms that we talk about is what we call the post-intensive care syndrome, or PICS. And so this didn't start to get into the lay press about in the COVID era. So this is when COVID patients were staying in the ICU for a long time. This is the first time it kind of got put into the Washington Post, a couple articles, and that after the ICU care, and what does that look like? And so I wanted to click over and just show you, it's a longer clip if you want to watch it, but Nancy Andrews is just an intelligent, normal female, young, in her 40s when she got into the ICU. I'm only going to play 3 minutes of this for you, just so you kind of hear. It's so much better coming from her, but it's about a 17-minute video if you want to watch it.
For 3 weeks, I was held in a room. If I tried to get away, they would tie me to the bed. I couldn't eat. I could barely sleep, and I couldn't speak. Groups of people would come into the room and look at me and talk about me and sometimes undress me. I was shot full of drugs. I was too weak to move. I couldn't see my body, but I had been cut nearly in half. There was insects on the walls and ceiling. I was in a boat in the bottom of an underground waterway. I was in a deep well. I was tethered to the ground by rubber tubes attached to my genitals. I was in a space pod. I was on a raft, in a library, in a conference room, in a fly-by-night health clinic. I was in the Arctic. I was in the desert. They were trying to kill me. They would try to get me into a room separate from everyone else or wait till late at night. I had found out about their secret pornography ring. I tried to tell my partner about this in hushed tones because I didn't want them to hear me and redouble their efforts. Where was I? They asked me this every day, and I didn't know the answer. I was in the intensive care unit, the ICU of one of the best hospitals in the world, where doctors and nurses were using the most current medical technologies and know-how to save my life. A few months later, after I'd gotten home from the hospital, I went to see the surgeon for a checkup. And I told him about these terrible memories and the resulting diagnosis of PTSD. He said, "PTS what?" People don't generally remember anything from the ICU. Why then was I having nightmares and flashbacks and sleeplessness? Was it because I was weak? Did I lack resilience? Was I too sensitive? Was I crazy? Why was it so hard to do the things in my life that previously had been fairly easy? Why couldn't I seem to move forward? And why wasn't I perfect the way the surgeon said I would be when I recovered physically?
Yeah, so I just wanted you to hear it because I know in my training, and I think a lot of our trainings, we hear the same thing, is that you're in the ICU, they're sedated, they don't know anything, they don't remember. But I'll tell you, after following these patients and doing these things, and we'll talk about this a little bit more later, but they do remember the things that we do to them every single day in the ICU. And it leaves long-term memories that they can't really figure out why they're having them. And so this is a real thing. There's a great New England Journal of Medicine article out in 2013 that really talks about the long-term cognitive impairment. So there's a big study, probably one of the bigger studies that I've seen so far, is just 800 patients in the secure MICU with respiratory failure or shock. Only 6% of them at baseline, importantly, had a cognitive impairment, but about 74% of them developed delirium during their hospital stay. And then they followed them post-discharge at 3 months and 12 months. And so what you could see, so this is your global cognition score. So 100 is normal. So I just started off with the greater than 65-year-old group, and you can see that both 3 months and 12 months after discharge, they meet criteria for TBI, mild cognitive impairment. Like, okay, those are the older population. That makes a little bit of sense. But if you then look over that 50 to 64, and then even the younger than 49 year, it's exactly the same. So this isn't necessarily, and this is actually correlates with the number of days of delirium, not the use of sedatives, not the use of benzos, and not, again, baseline cognitive impairment issues. And so this is a really big, significant issue, I think, that we are just starting to pay attention to. And so I think it's really important. And so about 20% of ICU patients actually go on to develop what we call chronic critical illness, or an ICU stay greater than 14 days. And what we kind of fail to think about sometimes is trauma, sepsis, any of the patients that come in with that initial diagnosis, even after, they come in, they get multiple organ failure, they get secondary infections, they have all these other secondary inflammatory insults that they still have to heal. So that even after that first event is over, there's still all this other things, the sequelae of that critical illness, wound complications. And so this results in the persistent activation of the inflammatory response, and these patients are functionally immunosuppressed for months. And I think we've had a great amount of published in the burn literature about how they maintain immunosuppression and they're catabolic for a year after discharge. But this is actually the case for a lot of patients that come into the ICU. And this requires extreme amounts of energy. And that's why these patients get significant loss of lean body mass despite what we call optimal nutrition. And so this actually constellation of symptoms that you talk about, the secondary infections, the persistent activation, this was coined the persistent inflammation, immunosuppression, and catabolism syndrome a few years ago by the Florida group, and also called PICS. So as a simple surgeon that I am, I could just say I study PICS and I don't have to really get into it, which is great. So, but early intervention, and it seems like any ways that we can minimize ICU length of stay is really key to mitigating both types of PICS. And so the barriers to this is we really can't tell who's going to develop either type of PICS, right? So you usually recognize it when it's already present. So we're rounding in the ICU and you're like, oh, this patient's been here for a couple of weeks. We kind of aren't doing anything, but they're still sick. We don't know what to do. And so like, oh yeah, they have PICS. But it's like, we don't really know who's going to come in and develop it eventually. We don't understand the mechanisms of immunosuppression. I'll tell you, I've been studying this for 20 years and we still don't understand it. And we don't know the optimal timing of intervention as a result. So I'm going to take you guys back a little bit and maybe kind of talk about why and some of the kind of more nerdy parts of what I do, and then get into kind of the more clinical and how the things we can do on the other end of things. So just to review, for some of you forget the normal response to injury and infection, this is mostly for Liz. So you've got any sort of trauma, foreign pathogens or tissue damage. So an infection or traumatic injury, you get the local release of inflammatory mediators, you get the activation of your innate immune response, the neutrophils, the macrophages, they migrate to the site, they do their thing, they eat the bacteria, they clear up all the damaged tissues, they present antigens to T and B cells, they get activated. And between this whole system together, you get efficient and effective clearance of all that damaged tissue and pathogens, right? Really importantly, though, also is the resolution of that inflammatory response, right? So it's really important that this whole thing turns off, so it's not this continual cycle. But what I'll say, and part of that, I'll put an asterisk about step 3 right here. And so when that innate immune system gets activated, they start to trigger either apoptosis or other feedback mechanisms to trigger your deactivation. Again, it's really, really, really important for that response to turn off. And so this whole cycle works really well for small hits, right? But if you get something really bad, a really terrible septic event, belly full of poop, bad trauma. And so that after that initial wave of neutrophils and macrophages come in, they're already turned off, right? And so if you still have a lot of things to clear up or a lot of bacteria to clear up, that initial wave of immune cells aren't there. These feedback loops trigger early depletion and decreased activation, again, as a mechanism to turn everything off. But if this is in the case, you have kind of multiple layers of immunosuppression at this point. You have decreased clearance of the bacteria and cellular debris. You have continued local release of inflammatory mediators, and this results in that persistent inflammatory response, and that cycle just can happen for weeks and weeks and weeks. And with this, and that's really where we see this profound catabolism that you see in these even 20-something-year-olds get lean muscle mass even after a few weeks in the hospital. And so there is a feedback mechanism that, can replenish all of these neutrophils and macrophages. So you get this emergency myelopoiesis, the bone marrow starts shoving out new innate immune cells, but these cells don't actually have time to mature. They're just trying to crank them out as best as possible. The spleen starts making more, but it's actually kind of less responsive immune cells. So that's actually providing another layer of immune suppression. And so with this, I'm not going to talk about the catabolism part of it, but this is a huge part that we're just starting to scratch the surface on. There's a group, Paul Wishmeyer out and Duke did this great study. There's this ultrasound that actually not only measure the muscle thickness, can watch the muscle kind of go away, but it can measure the glycogen content. And it's backed up by actual muscle biopsies testing for glycogen content. And so if you look at the score, this is kind of relative units of the glycogen scores of like a rested athlete versus post a soccer match. You get this and this and this. So we started putting this probe on ICU patients. And so it's people, once you have a patient in the ICU greater than 7 days, this is your glycogen content. So you completely deplete. It's not even like all of your muscle stores, right? So this is pretty significant, pretty drastic. So what do we do? How do we figure this out? We put in mice, right? And we start the process of, so we've built a model of PICS. So we use outbred mice for reasons we can talk about later, but from an immune standpoint, we put them to sleep and open their belly. We either close them back up and don't do anything, or we do what's called a cecal ligation and puncture. So the mouse cecum is actually really long. That's kind of like part of their appendix as well. So if you ligate about a third of it, you puncture with a single puncture with a 25 gauge needle, kind of make some poop kind of come out a little bit, give them some antibiotics, close them up and monitor them for 8 days. You get about a 20% mortality. And then more importantly, so this is pretty similar to what we see in like a septic kind of population, but all the survivors of this develop PICS type of phenotype by day 8. And so what I be very clear with us, this is really modeling intra-abdominal infection without surgical source control. So this is like your perforated diverticulitis that for some reason you don't operate on, perforated appendicitis, or an anastomotic leak that you're 10 days out and you don't want to take them back to the OR, right? So this is the kind of model that we're using in the mice. And so what we see is the various types, and I'll go through the different PICS phenotypes. So you get persistent leukocytosis. Again, this is day 8 after their cecal ligation. So they've got a lot of neutrophils in the blood, bone marrow, and spleen, a lot of immature macrophages in the spleen, about 15 times more than the sham animals. You get T cell depletion, so both CD4 and CD8 T cells, in particular, your naive CD4 and CD8 T cells. So you get early depletion. You can't really respond to those secondary infections, right? And then you get pretty profound catabolism. So you just look at the weight. So after the first day or so, the mice aren't eating as much, but their weight loss happens pretty significantly and immediately, and it doesn't really recover over 2 weeks time. And you look at their muscle mass, it's about 50% of the mass of the sham animal. And if you throw them on a rotorod, it's like a kind of spinning wheel to watch how they can stay and be coordinated. They spend about a minute less on average than a sham animal. And then most importantly, they have an increased susceptibility to secondary infection. So on that day 8 time point, if you put intranasal Pseudomonas, there's about all the mice should clear that in a sham animal, and none of them die, but about 20% of them die. And even on the first 24 hours, you have a pretty significant increase in bacterial burden in the lungs. And so this is kind of the systemic effects as well. I think is really important that it also shows it's that secondary inflammatory response too, that you get that secondary organ damage that causes a lot of the problems as well. So in this model, we actually have a change in the lungs as well. You get all these microthrombi. These kind of picture of an untouched mouse versus a trichrome stain that shows fibrin deposition. You see this all over the lungs in the PICS mice. Since this is a microthrombi per field is pretty significantly elevated. And then if you throw them in a plethysmography to actually look at lung function, you've got decreased tidal volumes and increased respiratory rate. So functional changes as well. You've got a lot of coagulation changes. You get consumptive coagulopathy like you do in like a septic patient. And then interestingly is what we started looking into the spleen, and what we started to see is that in an untouched mouse, this is about the size of a spleen. And the people in my lab started noticing that these spleens are huge. We don't know why. So we started looking into it a little bit more. So the mass obviously is much more, but it's splenocyte. So it's actual cell mass, not just edema. And if you look at the architecture, so this is, if you guys remember back to your histology of the spleen, you've got these nice little germinal centers in an untouched mouse with the white pulp and the red pulp. In the PICS mice, the spleen is complete disorganized architecture. So you're talking about the place that T cells and B cells mature. You don't have that infrastructure that you have in an untouched mouse. And you also see a lot of megakaryocytes, interestingly, which is an area that we're starting to try to figure out. And what I learned in medical school was that, the spleen is where innate immune cells go to die, right? So are these just a bunch of dead white blood cells that went and did their thing and are dead? But if you stain them for all the apoptotic stains, if you look for necrosis, they're not dead and they're not apoptotic. They're actually alive and they're actually proliferating. And the spleen is a source of proliferation for these. And so one of the things our lab is interested in is that first neutrophil wave. So there's a lot of people that study the T cell responses, the B cell responses, but I think it's really important to study that whole spectrum, right? The neutrophils and that first wave of immune response is what sets everything up for the remainder of the responses. And so we used to think that neutrophils in particular, right, your foot soldiers, they just non-specifically go to the site, they kill everything, and then they die, is what we always used to think. But I stole this figure. We're actually finding out it's not quite the case. Some of them do. But so these neutrophils of this figure this is a blood component up here at the top. This is a tissue component. And then at the lower here is the lymphatic component. And so what we actually can see is that, so neutrophils will come and they use binding to endothelial cells by ICAM or CD54 is a really important step. It's actually a covalent bond that they form with the CD11B in order to transmigrate into the tissue itself. And so it actually picks up that ICAM from the endothelial cells. And so not all of them die, because what we can see, we can reverse transmigrate back into the bloodstream. And so what you see on these cell populations is they get ICAM high, which normally neutrophils shouldn't have. And they actually have the chemokine receptors. So CXCR1, CXCR2 are their main chemokine receptors. When they bind, those receptors get internalized. So those are low chemokine receptor, high ICAM population. And so we think that these CD54 high chemokine low neutrophils can migrate back to the lymph system, perhaps back to the spleen. That hasn't been looked at until now. And so we started looking at it in the spleen. And so in an untouched mouse, you really don't have a lot of neutrophils in the spleen. So the low versus high population in the untouched mouse is not going to be much different. But if you look at our PICS mice, tons of neutrophils, tons and tons and tons of neutrophils. You've got both. You've got both a CD54 high and a 54 low population. And if you look at the time course here, again, the circles are untouched. I'm not going to focus on that. But if you look at the squares, so the CD54 high population, which is the closed squares, starts to go up about day 6 or so, maybe come down or stay the same about day 8. But then the CD54 low population really starts to skyrocket in the spleen. And so we looked at function between these two. So just the graphs on this page here. So the left side is the total population of neutrophils in the spleen, just the PICS mice. So there's no sham mice here, because then not a lot of neutrophils. And then on the right side here, we're distinguishing between the CD54 high and 54 low populations. And so reactive oxygen species, which is a big part of what neutrophils do, right? They're significantly less than the CD54 neutrophils. This photo, which is a test to determine the phagocytosis capacity, the CD54 low, significantly less capacity. Netosis, ability to secrete neutrophil extracellular traps, which is a big part of that bacterial, killing bacterial, significantly lower. And then if you look at the chemotaxis on the opposite end, what I'd say is the CD54 low population, again, these are not going to have receptor internalization. This is about the normal level of chemotaxis, and the CD54 high level is decreased chemotaxis. So it fits along with what we're seeing so far. And so this is really concerning, because if really the CD54 low population is really accumulating in the spleen at that day 8 time point, they have significantly lower level of function and they have increased level of chemotaxis. So if there is a secondary infection, are these the neutrophil populations that are responding to it? And so I'm going to kind of divert my talk right now to kind of get into the more clinical things, but essentially, this is really interesting to us right now. There's a huge a number of people right now that are looking at neutrophil heterogeneity. It is the first thing and the first level of immunosuppression that's happening. So our next steps in here is to really determine and look at the later time points and really figure out the differences in these. Are these CD54 low populations really the cells responding to that secondary time point? How are they interacting with the T cells? Are they really responsible for that immune checkpoint inhibitors that lead to early apoptosis? And then again, figuring out if they're really decreased chemotaxis to other sites. And then more importantly, right, do we care at all about, is this even relevant to humans? So taking it back to the bedside, so that's kind of all the animal model. And so we've got a prospective observational trial ongoing that I started at Cincinnati. We've got about 110 patients so far, and really looking at a whole bunch of different immune parameters to look at whether we can predict which patients progress to PICS. And so we look at which immune dysfunction parameters can predict that prolonged ICU stay, and then whether there's certain phenotypes that are associated with that. And so we prospectively draw their blood out to day 28, and we've actually separated critically ill infected patients for critically ill non-infected. Those are for our population, and here is really mostly trauma patients. I think it's really important to differentiate between those immune responses. Excluded people if they were immunosuppressed, obviously. So we've got half and half about infected versus non-infected patients. And then I kind of combine those groups together here, and I'm comparing what we call rapid recovery. So patients in the ICU less than 7 days versus those that stay on for greater than 20 or greater than 14 days. And as you can see, it's about 20% of the patient population, similar to the literature. And what you see here, the statistically significant things aren't really, there's no differences in the age, maybe slight differences in sex. And I think it's because mostly trauma patients are male. No differences in race, no differences in BMI or comorbidities. Certainly the patients who have chronic critical illness are going to have greater SOFA scores. They're going to obviously have greater hospital and ICU length of stay, but there's actually no difference in mortality in that acute phase, which is interesting. So despite the fact that they have prolonged, there's these typical things that we think of: age, BMI, comorbidities. Those aren't the things that we are holding on to that we used to think was the major factors in that chronic critical illness. So we started looking at, this is just kind of raw data right here. We haven't done the full on adjusted analysis yet. We're still, the study's ongoing. I started it at UT Southwestern as well. We are starting to see some signals. So for instance, the monocytes have decreased HLA-DR in the early time points, which, predicts, and that's been shown in the literature as well. Some early immune checkpoint inhibitors, the neutrophils. We started looking at that CD54 high-low population. We're not quite seeing something that leads to much of anything, but I think, again, these are unadjusted, and the heterogeneity that we see, and especially that day 1 to 2 time point, is just tremendous. So we're not getting a ton of signals. And the T cell response as well. You might have some early decrease in T cell responses. So sorry, the red circles are the chronic critical illness versus the rapid recovery patients. So there might be some signals that we're starting to see right now, but essentially we have 92 different variables that we're looking at right now. So we started partnering with the bioinformatics team at UT Southwestern, and we're doing some machine learning studies. And so we've now looked for the day 1 time point, the day 7 time point, the differences between day 1 and day 7, piecing apart, doing all sorts of machine learning techniques. And I can tell you right now, with everything, we've been working with them for 8 months, and the best signal that we can get in that noise is an R-squared of 0.277. So I think, and we're getting things a factor of importance, like that we already know, like obviously if they're sicker, they're going to stay there longer. So really simple things, but none of these immune parameters that we're looking at are showing that signals through the noise. There's a lot going on that we still have to figure out. And so this is ongoing. This is something that we're still trying to piece apart and really look at the nuances between the different immune responses. But I'll tell you, the heterogeneity and the way people present are so different. And that's really, the people that are doing this around the country are really focusing on that individualized immune phenotype to really figure out how to manage these patients. Some patients come in with TNF responses through the roof. Some patients don't. And none of those predict whether they're going to be in the ICU for a long time or not. So I'll kind of pivot a little bit into our, so this is clinically the basic science stuff to kind of, what do we do at this point? So how do we win this war? I say that we've learned to help make them live, but we need to learn how to help them survive afterwards as well. So I'm working on the front end, try to figure out the immune function, but what do we know for right now? So what we know for now is that to mitigate PICs, both kind of PICs, really supporting that immune system. So there's a lot of data out there right now that is still not quite, is a little granular still about promoting gut health and the microbiome. We're still going back and forth about immune boosting nutrition. That pendulum has swung back and forth for the lab. Shameless plug for following my work. And then supporting the catabolism. Again, all this process really, really, really drives that catabolic response. And I still don't think we feed these patients the right way. But supporting the muscle resistance, there's a lot of data out there right now to really monitor that catabolism and that muscle performance, like kind of elite athlete training, like that ultrasound that we were showing. And then adding supplements when needed. I think for those of you who do the ICU care, there's been a lot of studies out there lately about vitamin C and thiamine. And all I'd say is low threshold for starting it. Basically, thiamine and vitamin C are the 2 cofactors for every rate limiting step in every single metabolic response. So thiamine and vitamin C is kind of the only thing right now that's maybe supportive of helping the catabolism response. But more than anything, I think the Society for Critical Care Medicine is really pushing forward this after the ICU care. So this is kind of what I want to end and focus on at the last part of the talk, is really, I think there's a push towards a lot of the level 1 academic centers to put efforts into these post-ICU clinics. So we built this at the University of Cincinnati. It's basically a multidisciplinary ICU recovery program, very similar to like a multidisciplinary cancer visit, where they see an ICU physician. So most of these patients at this point, after I started tracking them and following them for a number of months after discharge, We thought we did a great job at getting our trauma patients and our acute care patients back and seen in the clinic. And I'll tell you, once they go off to that facility and they have most of the patients that we're dealing with here, right? They're delirious, they're trach, they're going to some facility, they don't know who they are. It's really difficult to get them to come back to clinic, and they kind of get lost in the system. They end up back at their primary care physician 6 months after discharge with a huge file of what their ICU stay was and what happened to them. And I'll tell you, that's just not paid attention to, right? And so this ICU recovery program, you're really taking that ICU physician into the clinic, both the MICU physicians as well, to review the events of our ICU stay, and I address all medical related issues from the ICU, right? How many medications, beta blockers, all these other things that we start in the ICU. Sure, primary care docs can probably wean some of these, but they end up staying on these medications where they don't even need to. We screen for that anxiety, depression, PTSD, and neurocognitive issues, which their primary care is not even going to know to do. And these are pretty significant. I'll show you some data in a second. We have a dietitian that comes in. I'll tell you, even at the 3-month time point, these patients meet all criteria for malnutrition. Even if they're home and eating, they still are very catabolic. We have an ICU pharmacist come to the visits as well. Again, all the medication reconciliation, we do a lot of streamlining in terms of weaning everything that we possibly can. All that Seroquel patients get discharged on, you know how long that takes for their primary care docs to wean? Because I'll tell you, they don't wean them at the facilities. And then the probably most important thing is that nurse case manager to come with that transitions of care. Once they go from, facility to SNF or SNF to home or home to work, right? So these patients, trying to get them back into doing what they used to be doing. And we kind of we follow them out to a year after discharge and create a survivorship plan. And really at that end transition point, we work with their primary care physicians to transition back to kind of the normal medical field. So this has been a really rewarding actual part of my practice. And so at University of Cincinnati, which I now recognize, Liz, as you told me yesterday, you shouldn't put acronyms that people don't know, because UC is not University of Colorado, but University of Cincinnati. We tracked all patients in the surgical ICU that were there for greater than 14 days. We kind of cherry picked and we wanted to focus on patients that we knew were going to get better, or that we could help with this type of program. So the 80-year-old who has multiple trauma that goes to a SNF that don't know that I'm going to help her, we don't really enroll them. The patients that we know that are going to do fine when they're discharged and they're eating, they're doing everything fine, there's not issues with neurocognitive issues, we don't really enroll those either. But it's that patient population that needs to get back to school, get back to work, that we really focus on. We enrolled 28 patients, and then 119 were not enrolled. And as you can see, they're young, right? They're not these old decrepit people. The mean age is 40, 50 years old. Big range from 21 to 72. And then just as a point, I put here the percent with a tracheostomy. So about 3/4 of the patients that we have in our program have a trach, just saying that these patients were really sick in the hospital. And certainly their length of stay on average was about a month. So they're in the hospital a month and in the ICU for a month, right? So long period of time in the ICU. And I think what's really important here, just as kind of a marker of how sick these patients are, just the patients that we've enrolled, the average charges for that index admissions, it's over $1 million. And so we talk about in some of the issues, because these visits take a long time. You take hours to go through all the things with these patients. And so it's not a revenue generating clinic by any means. We can only see a couple of patients in an afternoon, but even with a collections rate of 30% or 20%, those patients we've already collected all their money. And so part of the conversations of here is how to make sure these programs can be sustained, not being money generating. Again, looking at 30-day post-index, and then for 28 patients total, between their index admission and 30 days post-index admissions, there's charges of $37 million for just 28 patients, right? This is tremendous. And so we looked at the number of the differences between patients that we enrolled and didn't enroll. So the patients we didn't enroll, they missed about 40% of the visits that we scheduled them for we followed their charts, and they never got back to those appointments. They never rescheduled. And then we looked at ED utilization and readmissions within that year after discharge. They're pretty similar in those that are enrolled and not enrolled. And I would say that I don't know that that's ever going to change, even with a bigger patient population, because these are really sick patients. I don't think the goal is to have 0 ED visits and 0 readmissions. They're going to get readmitted most likely. But what we talk about is preventable ED admissions and ED visits and readmissions. And so if you look at, and what I call preventable is basically if they had the system, if they had somebody to call for the issues that they're having, could we have prevented that ED visit? Could we have prevented that readmission? And so it's a little bit subjective, but what we ended up getting is, so ED visits for the non-enrolled is about 43% of patients, about half of that in our enrolled patient populations. And then looking at 1-year readmissions, for those not enrolled, about 7%. had readmissions versus 0% were preventable. So they had a number of readmissions, but we would call 0% of them preventable. They came in septic. There's no way we could have helped them as an outpatient. And so tracking the outcomes of the patients that we did follow, we looked at 1 month, 3 months, 6 months, 9 months, and 12 months, and all these kind of screenings, and like very similar to the literature. So even at a year after discharge, a pretty significant number of them are screening positive for anxiety, depression, PTSD. Again, the medication changes and the reconciliation we do is pretty tremendous. And then we do, our patients do miss their appointments as well, but we are able to reschedule every single one of them. And so that's a huge part of kind of that ongoing, especially our trauma patients, right? They have 5 different subspecialists to see. Those facilities don't transport them to their visits. And so to make sure we have to call the places, they need to come to their appointments, all that kind of thing. So just next steps and kind of final thoughts. So for our lab, we're going to continue the mirroring model of P.H.C.S, looking at that neutrophil heterogeneity. How does that affect subsequent immune responses? Does that low functioning neutrophils respond to secondary responses? And can we really look at individualized therapies to improve that early neutrophil function to set up the remainder of the response to be at least better? We're really deep diving into this catabolism aspect of it. We just bought that muscle ultrasound again. We're going to start looking pretty deeply into the connection between the immune system and the catabolic response, and looking at any sorts of interventions that we can do that would potentially decrease that amount of protein wasting that happens. Again, just like I think about giving Tylenol to a fever, like, do we give that? Do we not give it? Is the fever good? Is that a good response? This particular patient population is they're starving for energy, right? Every single cell in their body is requiring large amounts of energy. And so they're going to be catabolic. And so all the studies that we've looked at in terms of like giving anabolic steroids, those haven't really come to play because it's really not, they're going to be catabolic. And how do we best support that? We really don't know that. And then we're starting to develop the ICU recovery program at UT Southwestern as well. At Cincinnati, we've now engaged the MICU and CVICU survivors. So it's a big, huge clinic where any ICU patient can come for that, following that after discharge. And we're going to start to follow that immune function and catabolism all the way out to a year. And then certainly the career goal and everything that I'd love to do is have some sort of interventional human study with some individualized immune modifying therapies to reduce or mitigate both types of P.H.C.S. And so just final thoughts, I think it's really important to know that, our heroic efforts, like Nancy Andrews was saying, the surgeon, they go see their surgeon in the office and they say, no, everything's going to be fine. Here's some complications, it could leak, it could break down, but what does that actually mean? It doesn't mean a month later in the ICU, having gone multiple operations, you don't even know who you are anymore. Just need to recognize that our heroic efforts in that acute phase do not always create healthy, long-lasting survivors. And that physiologic response to prolonged ICU care can be profoundly debilitating. And there's this great article that talks about it actually creates a crisis of character. They completely lose who they are and where they're at in life. It's really disruptive. And so I think to give your ICU survivors the best chance for a meaningful recovery at this point, just my kind of body of work, certainly the ICU bundles, everything that we do for the ICU patients, minimize that delirium, minimize their ICU length of stay is really critical. Recognize that every single extra day in the ICU increases the chance of both types of P.H.C.S. So doing everything we can to support the immune system, get your patients fed early, support that profound catabolic response, and then continue to support through ICU recovery programs. And so with that, I'll like to thank my lab members, both at University of Cincinnati and then also at UT Southwestern, and then certainly NIGMS for the funding for all this work. I'd like to take any questions.
First of all, again, thank you so much for coming and delivering this talk. It's a really incredible body of work. And what I love about it is it spans the whole spectrum from basic to translational to clinical and beyond. So, I have 2 questions. The first one maybe is not really meant to be answered and is more philosophical. But, we've evolved all these mechanisms over many years, millions of years. And when you're trying to tweak them, how do you know whether you're actually hurting our overall response versus helping it? Because, having a fever, for example, it doesn't hurt us, or is it protective, or is it both, right? So, how do you find that point where you should begin to interfere or you should let it play out, because this is what's evolved over millions of years? Why don't I stop there?
Yeah,
And then I'll ask.
I
my
love
second
that question. It's that burning question in my mind too. And like I said, doing this and studying the basic science of this for 20 years, I couldn't answer that question at all. And, just the silly things like TNF. Do you block? Like, how many studies have you did anti-TNF, anti-IL-1? None of those studies work. What's too high? Is high TNF bad? Is it good? We have literally no idea, not any idea. So my strategy, at least from everything that I've studied so far, I think to your point, that first response, everybody's really eager and salivating to intervene in that first 24 hours. Probably come because of trauma, right? We need to intervene in the first hour. We need to give antibiotics for sepsis in the first hour. People are focusing on that first 24 hours and intervening then. I almost feel like just let them do their thing that first day. I'm going to look at you in day 3, day 5, day 7. Now, what are you doing? What did your how did your immune system change? Are you still on fire? Right? Because we see, you see somebody coming on fire, they're on 3 pressors, septic is all get out. Some of patients get better really quickly and some of them don't. No idea what's the difference between them. That person with that on fire, with that high TNF response, but they got better. And you didn't know, you don't know how to predict that. And so do you intervene? Do you not intervene? So my gut instinct almost, I think, as we start to really dig into this and answer these hard questions, is I'm almost predilection to keep that initial event to happen. And then let's see what their delta is and then go from there. I think that from first step standpoint of figuring that question out, I think is going to be critical, at least as we start to progress the field. But my top burning question, yeah.
Great. And part 2. So you probably already thought of this and you may have done it already, but it seems like you have kind of a almost natural experiment. So you focus a lot on what's going on in the spleen. So you must have 3 patient populations: those who have trauma and don't have a spleen, those who have trauma and get a splenectomy, and those who have trauma and you leave their spleen in. And, maybe that's a natural experiment that you could follow, because if your hypothesis is there's a lot of disorganization in the spleen that is either causing disorganized inflammation or not, maybe that's a way to get a handle, at least a little bit of a handle on it.
I'll out myself a little bit and not answer the question to say that in humans, this may not be going on to the extent that it is going on in mice. I think because when we look at, we have, in the patient in the SICU, they get scans weekly almost. Sometimes these really sick patients, I will see and I will actively look at their psoas muscles just decreasing and decreasing and decreasing over time for the catabolism. They don't get splenomegaly though. And then when I ask the pathologists that actually study these kinds of things, they're like, I don't think this is probably happening in humans in the spleen itself. But this is where, yes, to study both the bone marrow response and the splenic response. The people, I haven't done the exact study with the human trauma population, but others have. And it's not totally coming out to the way that I'm seeing in the animal study. So we might have to take a pivot and look at the way that we evaluate the immune system might be a little bit different. So
Great. Thank you.
Thank you. Yes, Liz. Dr. Kovacs, excuse me.
So one of the things that you are not doing in your mouse model that you are doing in your patient population is long-term cognitive function. And we're starting to do that after burn injury in our mouse model because we see obviously ICU stays in burn patients cause delirium, dementia, PTSD. So I don't know how long you can keep your animal model alive, but there are many rodent versions of cognitive function that can be assessed that I'd be happy to talk to you about.
Yeah, I agree.
Eventually.
And there are postmortem studies, and I think the biggest one is in sepsis patients, and the degree of neuroinflammation is profound. And so I think that's probably a big part of it. But yeah, we have not carried out the behavioral stuff in the mice just yet, but I would imagine when they do, if they survive the first couple of days, they're going to survive. And so there's certainly an opportunity to look at function.
There are a couple of papers looking at burn at 1 and 3 months after burn injury in mice.
Okay.
That is where we got our start.
Awesome.
Other question is about gut microbiome. The gut controls the world. The New York Times said so. So I believe it. Are there interventions that you've thought of either in the animal model or in patients?
Yeah, I feel like the microbiome, which is not my expertise at all, but everything I read about it, I think it's still, at least in the humans, a little bit in its infancy of understanding, number one, which, commensal versus pathogenic bacteria, which are good, which are bad. I think we know which are good versus bad, but how do you restore that? So there's great data to show ICU patients in general, sepsis patients, the drastic change in the microbiome and the populations of bacteria. I imagine it has to play a significant role in this. Again, I think that it's still in its immaturity phase in terms of understanding exactly what the microbiome plays in it. So I've kind of stayed away from it because it's such a big body of work. But yeah, I'm sure that's absolutely playing a role as well. In the back.
Great presentation, a lot of food for thought. To add to Dr. Schulich's question and comment, maybe there's a fourth subgroup. Based on your data, do you think there's a role for splenic autotransplantation? In other words, is a little bit of spleen better than no spleen?
That's a great question. I think the literature I know is only in trauma, where they tried to reimplant little splenials or spleen pieces in the belly, and that none of that has panned out necessarily. And again, outing myself a little bit, I don't know that the spleen is playing as big a role as it is in the mouse, but the bone marrow response and manipulation of the immune system, the other completely other level of the problem that is really difficult to get to in the humans, right, is what's happening. We're only looking in the blood. And that tells you nothing about what's actually happening at the tissue level. And so what is your immune response happening in all these organ systems? We have absolutely no idea. So we're reflecting based on just what we're seeing in the blood. There's been no studies looking at the tissue level other than like doing bronchoalveolar lavage, which is telling you what's going on in the alveolar spaces, not necessarily in the lungs, right? So great question though. I think it's a great question.
Okay. Great talk. How do you prep the patient's families and things like that with all this knowledge you have that survival is probably different than what they're thinking it is? And how do you not terrify everyone doing it?
It is a great question. I've definitely, my thought process, the way I practice has changed a lot since I've seen these patients in post-ICU recovery clinic. I've approached it a little bit of the using the best case, worst case scenario is my process. And worst case scenario, I think what I've seen over the years is just, I can talk till I'm blue in the face and tell them all these things. And until you're actually going through it, none of it really processes in their mind. So I've tried to go really far down the pathway of explaining it. And they're like, okay, great, we still want surgery. Or someone comes in for trauma or bad, perforated, whatever, viscous. I lay as much crepe as I possibly can, but it's hard to tell somebody and explain to somebody that there's many worse things than death, which is what we see a lot, right, in the surgical ICU. And it's been difficult to explain it to the level that patients can actually understand and grasp it. But I do everything possible not to paint rosy flowers on anything anymore. And when they are in the ICU, I do a lot more interaction engagement with the families than I used to, in terms of here's where we're at and this is where things might look in the future. I have that information a little bit better. Again, I got trained that everybody forgets everything in the ICU, and it's the stories you hear are wild. They have these memories of things that are just bizarre. And so there's not even no way that you can explain to somebody who's never gone through anything like this before. It's really difficult, but there's no rosiness on anything I do anymore. So, and I give patients and their family members a lot more out in terms of we can keep going, but this is what this could look at in the worst case scenarios. This is what we want. I do a lot more of that up front and in the ICU than I did before. Great question. Great. Oh, yeah.
So you made the case that this was very mediated by the immune system in response to sepsis and trauma, and we've just been through a few years of experience with a pandemic, and that has resulted in an immune-mediated disease with a lot of prolonged ICU and long COVID syndrome. And a lot of institutions have set up long COVID clinics like we have here. So I wonder if you have an opportunity to partner with that group of people, plus study the differences between surgery, trauma, sepsis, and what a viral long ICU stay looks like.
Yeah, no, that's great. We had one our post-COVID clinic that was separate. I interacted in terms of our post-ICU clinic with those individuals, the MICU home critical care people. Their clinic, they don't necessarily get in this involved. I mean, these clinic visits are on average 2 hours per patient, and they don't get into that detail, but absolutely, there's parallel things that are happening, and then that long COVID type of phenotype, absolutely, it's a great partnership for sure. I think I saw somebody in the back. Yeah.
So, I love your talk. I love the living versus surviving. I love the part about informed consent and it being more than a surgical buy-in.
You are dealing with a huge mess of data. First off, congratulations. Second off, I hope you don't go crazy when you're in the lab, because I totally would. Suggestion, I don't know if it might, I shouldn't say I don't know if it might, it would decrease your generalizability, but with so much data and thinking that PICS is more of a phenotype than a disease in itself, it is a disease, but it's also a phenotype, and you can measure when you already have PICS. I don't know that you're ever going to be able to predict it. Is there an argument for, at least initially, while you're trying to define it, picking a subgroup of patients that are extremely similar, meaning, for example, the same GI pathology at the same distance and time from their initial injury with a similar clinical course, and measuring all your valuable variables in that patient population at that point of time, and then using that data to delineate what PICS phenotype looks like? Is the exact opposite of the big data, let's find the signal, and more of I'm seeing something, I want to measure it, and then focusing on how it applies. I think that's the only way you're actually going to get data on what actually PICS is, because the data is going to be a complete mess. Again, it's like a fever. So good luck with that.
Yeah. Yeah, no, it's the other conundrum too. There's a lot of different ways that we need to be approaching these data and collect. That's why we just collect everybody as much as possible. And then granularly down the way, you look at very similar to similar, right? Burn patients probably the best, because you can say this percent burn. This is the degree of secondary inflammation. That's probably the most specific, and then procedural. There's so many different questions about how to go about this too. People have tried the bottom up response. I'm trying the top down response. That supervised versus unsupervised analysis of all these data is a problem, right? The more data points you have, the more noise you're going to have and the less signal you're going to get. So but then, if you don't collect the right data up front, you're never going to get the signal that you need. You're going to look at the wrong signal. So it's the huge conundrum that I'm having smarter people than me to help me try to figure out. First of all, just a word of advice to people as you get older: when you don't know things, you just find people that do know instead of learning it yourself. But it's a great point. And I think I'll take it even to another level. I couldn't even tell you, I've talked to all the smart people that I know in this country. I've asked every single one of them, what's the appropriate control group? Not a single person can give me. Is it right? Sepsis average age of 50. You've got a ton of comorbidities, right? Is your control group an average age of 50 with these comorbidities? Is it a young, healthy person? Is it a kid? I have no idea. Not a single person can tell me what the appropriate control group is. So telling me if TNF too high of TNF alpha, I don't know what that is going to mean. So you're absolutely correct. It's a lot to try to figure out, as we talked last night. It's trying to utilize these big data people and machine learning things to really is going to be the way to sort this out. But great question.
Brilliant. Thank you.
When I was a resident, we were taught that patients could not eat for 7 or 10 days, and we're giving them 450 calories of glucose a day. What can we do nutritionally to anticipate the catabolic needs of our patients? Are there ways to give them the essential and conditionally essential amino acids and give them calorie dense, high fat foods so they can get calories when they're getting 450, but they're actually burning 3,000? Why are we still starving our patients for nutrients?
I have no idea. That's a great question. I don't know why you would starve your patients. Anyway, no, it's true. And what I would advocate for is really really using indirect calorimetry is as the gold standard right now to really actually understand what the energy utilization is. The data has swung so many different directions back and forth in terms of the supplementation, the amino acid supplementation, whether you add glutamine, do not add glutamine, the number of calories we overfed, we've underfed. None of those data have shown anything that gives us the sparkling answer of how to do it. But I think the only data that shows some value is early, even just trickle tube feeds early on to promote your microbiome, promote your gut health. But as quickly as possible, getting up to full tube feeds. But indirect calorimetry is probably the best thing we have right now to really understand what the energy utilization is, looking at whether you're preferentially oxidizing fat versus glucose. I think is going to be the key, at least right now, to understanding it. So, but yeah, feed your patients. I'll tell you, I don't think we feed them the right way, even what we're doing with the smartest nutritionist that I have. So.
Great. Thank you so much for an excellent talk, and we're really excited for you to spend some time with our students this morning. We have a swag bag from the University of Colorado for you. So thanks.
Thank you.
Of course, yeah. So next, we're going to move into our medical student research symposium. I know some people need to get to the operating room, but we're going to have a series of oral presentations and poster presentations. And as a reminder, our medical student summer research program is a 12-credit elective through the School of Medicine, where students are paired with mentors from the department. They have weekly didactic lectures and weekly work in progress meetings with a faculty member from the department. And so we're really excited to hear what our students have been working on. And if you are leaving, if you could keep the volume down, please. Yeah, if you're leaving, if you could just do it quietly so that we can move on with the rest of our program this morning. That was a student's presentation. No, oh, I'm sorry, you don't know. Students here. Okay, we're going to get started with our oral presentations first. We'll have a few minutes for questions after each talk. Our first presenter is Rebecca Davis, and she will actually be presenting on the prior students who were in the medical research program. Her talk is entitled Surgical Research Program for Medical Students, a Catalyst for Career Success.
Morning, everyone. Thank you for coming. I'm Rebecca Davis. I'm an MS2, and I'm here to talk about the Medical Student Summer Research Program that we're all participants of. I have no disclosures, and the work was supported by these grants. So before starting medical school, most students have a personal and professional interest in research. Some have had experience with research during their undergrad and gap years, but most have not had the opportunity to lead a project. As the value of medical students conducting their own research becomes increasingly important in residency applications, more and more medical schools are offering summer research programs. The University of Colorado Medical Student Research Program is a 12-credit elective consisting of a multifaceted approach to educating young researchers, including large group didactics, small group work in progress meetings, and one-on-one physician mentoring, as seen in the timeline on screen. The program culminates in this research symposium in which we are currently participating. In this mixed method study, we aim to evaluate medical student experiences and perceptions after participating in the MSRP, including effect on long-term career goals. So a web-based survey was sent to previous MSRP participants from the 2021 and 2022 cohorts. This survey evaluated prior research experience, the number and types of publications students produced since participating in the program, and how the program changed their feelings and their future career endeavors. Participants who responded to the web-based survey were invited to take part in a semi-structured interview, which was conducted over Zoom. The interviews were recorded, transcripts were coded, and common themes between interviews were identified. So of those emailed, 54% responded to the survey. The MSRP provided 93% of students a better understanding of all aspects of the research process. The MSRP received very positive reviews when participants were asked about their feelings towards the program. All the students agreed that the MSRP was a good experience for their career and that they developed abilities to pursue research questions. 93% of students agreed that their mentor was committed to their learning and that their confidence to produce quality research grew, and that they wanted to incorporate research into their long-term career goals. Of the 28 participants who were emailed, a quarter agreed to participate in a qualitative interview. The program's benefits can be categorized into 4 main themes. So the most commonly mentioned theme was about learning the research process. It was mentioned in every single interview, and the participants noted that the MSRP equipped them with the knowledge and skills to conduct all steps of research studies. Many students reported that the program helped teach them the intricacies of academia, and that the weekly didactics facilitated their understanding of proper research methodology. Going forward, participants indicated that they felt more prepared to engage with research beyond the MSRP and with helping them find, due to their program's instruction. The second most commonly mentioned theme was about mentorship. So every single interviewee credited the MSRP with helping them find an engaged research mentor. The third most common theme that we found is a change in the perception of careers in surgery. So many medical students have specific views of what a surgery career entails. However, the program demonstrated to students that many physicians are eager to serve as mentors for the next generation of doctors. Most students mentioned an increased interest in pursuing surgery as a specialty after the conclusion of the program. Students expressed hesitation around going into surgery or unawareness of the wide variety of careers a surgeon may take on. And our final theme that we found was an increased interest in future research endeavors. Following their participation in the MSRP, most students expressed newfound enthusiasm for careers that incorporate research. Students changed how they viewed research from a residency requirement to something that can have a lasting impact on the practice of medicine. So using the results of this study, we hope to continue to expand and improve the MSRP to expose more students to the appealing aspects of research and connect them with passionate mentors and peers. We would like to include more mentors and track the effects of the program as students move on to residency. So I'd like to thank Dr. Tevis for this opportunity and Dr. Madeline Higgins and Monica Adams for their help with this project. And I would also like to thank my fellow medical students for their support and feedback. Thank you.
This is, becoming more and more great of getting your CV out there and certainly you're playing a lot of places and hopefully can you tell me a little bit about your mapping process, where I do kind of have a pool of mentors that have agreed to participate in the program, or do you kind of have a med student pick up what mentor they want and kind of ask them to the program, or do you give part of what you're looking at right now? Really, what I'm trying to get at is the mismatch. Like, how do you avoid mismatches and mention what are the things that
So the way that when you sign up for this program, you can rank your top 3 choices of who you'd like to be as your mentor. And the mentors who sign up for this program are kind of committing to this program and are very interested in helping medical students. However, it's a really short timeline. It's only a 6-week program. So it is tough to, get that perfect match and have some kind of trials and errors. Like I know with other like PhDs, like you have more time to figure that out.
Getting instructive that in terms of what that's harder to be in general, but rise.
Yeah, every interview I had for the qualitative interviews, when we asked the survey, a lot of people don't like to type in like free answer statements. But when I did the qualitative interviews, I asked everybody what we could improve. And most people said it was just really hard to conduct research within 6 weeks. But that's kind of the constraints of our curriculum. Other than that, I, took notes about what we can improve on. And then for this year's cohort, for all of you guys, I'm going to be asking what we can improve for next year as well. Yeah. Thank you.
All right, our next speaker is Emily Hay Arthur, and her talk is entitled Lung Transplant Outcomes with Donation After Circulatory Death, Procured Lungs via Normothermic Regional Perfusion.
Hello. Okay, I have no conflicts of interest to disclose. Okay, let's start with some key terminology regarding transplants. First is DBD, or donation after brain death. This is what people classically think of as a transplant donor, someone who has undergone severe neurologic injury and meets all neurologic criteria for brain death and then undergoes transplantation. However, in an effort to increase the donor transplant pool, there's a second type of donor. This is donation after circulatory death. This is someone who has undergone severe neurologic injury that is irrecoverable, but does not meet the neurologic criteria for brain death. In this situation, after discussion with family, the patient is withdrawn from life-supporting care. They undergo a circulatory death, and then they can proceed with transplantation. There are different strategies for transplantation for this type of donor. One such strategy is direct procurement. This strategy, after declaration of death, the patient's organs are directly procured and flushed with a cold solution in preparation for transplant. Another technique is NRP, or normothermic regional perfusion. This technique establishes perfusion to organs for transplantation without establishing perfusion to the brain. I'm going to go into more detail with NRP as that is the focus of this talk. As I said, NRP applies to patients who have undergone a circulatory death. After declaration of death, the patient undergoes a sternotomy, then their brachiocephalic trunk, left common carotid artery, and left subclavian artery are cross-clamped. The patient is then hooked up to a cardiopulmonary bypass circuit, which perfuses the thoracic organs and abdominal organs without perfusing the brain. In this situation, after establishment of perfusion, the patient's organs can be reevaluated and transplant can proceed as appropriate. This technique strategy is increasing in popularity, specifically in the heart and the liver transplant field. However, it has not been as prevalent in the lung transplant field due to concerns of pulmonary edema due to the technique and resultant graft function. This leads into my project, which is to compare clinical outcomes of NRP and DBD lung transplants. We performed a retrospective single institution chart review of all lung transplants that occurred at Anschutz within the study period. This included 37 DBD lung allografts and 9 NRP allografts. Our primary outcome is survival through 1 year, and our secondary outcomes are listed here. Here are our results. In the top corner, you can see a Kaplan-Meier survival curve comparing NRP lungs to DBD lungs. Pictorially, you can see that these graphs are relatively similar, but a log rank test, which measures the time to an incident or death in this case, is statistically insignificant. Of note, not all transplant recipients have reached the 1 year mark post-op at this point, with patients in the NRP and DBD lung group as well. Another outcome we look at is the P to F ratio, which is an objective finding of pulmonary function, which can be used to help understand the graft function in these patients. In looking at P to F ratios at 0 hours, 1 day, 2 days, and 3 days post-op, there is no significant differences between the NRP group and the DBD group. Here we have a table of more outcomes that we looked at. I would like to direct your attention to ischemic times, which are not significantly different between the NRP group and the DBD group. PGD, or primary graft dysfunction at levels of 2 and up, are not significantly different between the DBD group and the NRP group at 0 hours, 1 day, and 2 day. At the 3-day mark, our NRP group had lower incidences of level 2s of PGD. Interestingly, our NRP group also had lower amounts of readmission within the 30-day period of post-op compared to the DBD group. However, overall incidences of readmission were the same. In conclusion, the study is largely limited by its limited size. We had a limited amount of transplants that occurred at our institution to compare, and we also have limited longitudinal data. As I said, not all transplant recipients have reached the 1-year outcome at this point. However, our outcomes in this emerging field are showing that NRP lungs are similar to DBD lungs in terms of clinical outcomes. Optimistically and conservatively, this is a positive outcome that is showing that these NRP lungs have positive post-operative outcomes and can be used to dramatically increase the donor transplant pool for lungs. Thank you.
To expand this to other centers, I always wonder whether Colorado and Long Beach being an altitude might impact results.
Yeah, that's a great question. As I said, I think this is the emerging center for the NRP lung program, but we have adjustments in our analysis for altitude, like the P to F ratios are adjusted. I'm not quite sure about other institutions plan to expand, but we're definitely continuing it here and plan to see this through further.
Are there any concerns with regards to the brain death donors and circulatory death donors? Exactly how to be calculated, maybe
Yeah, there has been a large amount of ethical conversations regarding the NRP program and the establishment of perfusion of organs that don't include the brain. This is definitely an ongoing conversation that still continues today. But as far as like ethicists go, this has been, the NRP protocol has been deemed appropriate as far as perfusion of thoracic and abdominal organs. But I think that's a great question that it will continue to, conversations will continue to go on. Yeah.
Do you all have any thoughts as to why they might have lower predictability?
I think this is largely due to our sample size. We only had 9 NRP lungs that we evaluated at this point. I think it's too early to say if that's, we had 0 incidences of readmission in those 9 patients, and I think it's too early to say if that's significant.
All right, our next speaker is Jasmine Gion. Her talk is entitled Attitudes and Perspectives on Tools for Shared Decision-Making Amongst Breast Surgical Oncologists.
Okay. Hi, again, my name is Jasmine Gion, and I'll be presenting on attitudes and perspectives on tools for shared decision-making amongst breast surgical oncologists. So currently for early stage breast cancer patients, surgery is the primary treatment option. And patients often have 2 options that they can choose between: a lumpectomy, which is when a portion of the breast tissue is removed, and a mastectomy when the entire breast tissue is removed. And these have equivalent oncological outcomes for early stage breast cancer patients. Therefore, patients often face a dilemma when choosing between these 2 options. And this is why shared decision-making is increasingly important for these patients. And this is just when a patient and a physician will come together and make a collaborative decision based on what is best for the patient and what their values and preferences are. And this is done through a variety of different ways, but today I'll be focusing on decision aids, which are actual tools that a physician can use. And this can be a variety of different ways. It can be a website, a video, a diagram, pictures, etc. And physicians will often use quality of life discussions and tools as well. And this is just kind of focusing on, like the different types of qualities of life between doing a lumpectomy and mastectomy. And then there are also tools to measure these outcomes for different patients that physicians will use in their shared decision-making process. However, in breast surgical oncology practices, there is still limited use of decision aids and these quality of life tools, and the reasons for their slow implementation are not well understood. Moreover, there is limited research on how breast cancer surgeons currently view decision aids and quality of life tools, and this is kind of where my project comes into play. So clinically active breast cancer surgeons were recruited from a national research group. Semi-structured interviews were conducted over Zoom, and all these interviews were recorded, transcribed, and qualitatively coded and analyzed using a thematic analysis approach. So as for the results, 12 breast cancer surgeons were interviewed, and they ranged from 3 to 30 years in practice and were from a variety of practice settings. And through the analysis, 4 main themes were found, and these were centered around the facilitators and the barriers around quality of discussion tools and facilitators and barriers of decision aids. So first, kind of focusing on the quality of life discussions and tools. These were some of the sub-themes that came from what facilitated using these tools and having these conversations. So physicians often talked about how it's important as it allowed them to understand what patient priorities were. They also believe that it was a patient's right to be fully educated and informed about their future quality of life. They thought it was the physician's role to use their expertise to set realistic expectations. And overall, they had positive thoughts on these quality of life tools and thought they were good for comparing different procedures. And on the right, you can read a sample quote that a physician said. On the other hand, there were also some barriers to using quality of life discussions and tools, and they're mostly centered on the actual instruments to measure quality of life. And physicians also talked about how they thought there was just a lack of training on using the quality of life tools, and they just weren't quite sure what to do with the information, even when they were collecting it on a day-to-day basis. And the next, the other themes were centered around decision aids. And some facilitators of decision aids were that physicians thought they were useful for patients. It helped if they had previous experience using decision aids. And they often also thought that they were helpful for select patients. However, many of the physicians also talked about some of the barriers to decision aids, and this ranged from being patient-specific, such as just some patients were just really overwhelmed and weren't quite conducive to using a decision aid. Surgeon-specific, if the surgeon's been in practice for many, many years and they just would rather not use a decision aid because they already have a set method of talking to patients. Specific to the decision aid, if a physician just didn't like this decision aid that they were using, time constraints, cultural and language constraints, and overall, some of the physicians also just had a preference to have a natural conversation with patients and not to use a tool in front of them. So overall, this project showed that breast surgical oncologists report limited use of decision aids and quality of life measurement tools due to several barriers. Some of these barriers that I talked about may be overcome easily, but some are more complex and may require nuanced interventions in the future. However, overall, shared decision-making is really important for breast cancer care, especially for those with early stage breast cancer. And it would allow us to make patient-centered decisions. Thank you.
Trying to figure out how much information is too much for patients, kind of along the I think your kind of data so far, it's probably a depends on patient rate and then depends on the physician access to that. Can you give some examples of the between the two pictures and what sorts of things are involved? And do you feel after looking at the qualitative things that it is too much information or too little information?
Sure. So most of the physicians that I interviewed, some of them use an official decision aid that is like published, that is just out there for physicians to use, or it's part of like their practice. Some of the hospitals they work at will kind of like have them use a book or a video. And then other physicians just kind of use an adapted form of a decision aid. So they have their own PowerPoint that they have made with diagrams to give out to patients while they're like talking. So it depends on the physician. And I haven't had a chance like look exactly what they use, but I think the physicians that have used it for many years, like they've adapted it so that it's good for the patient, it's not overwhelming, or they'll just kind of, if they do think the patient is overwhelmed, many of the patients noted how like they'll just make it individual for the patient. If the patient is just having too much right now, they'll just kind of push back and or just have another appointment for the next time to discuss it more.
Surgeon who has been working for 3 years versus 30 years in terms of their adaptation to the
Right. Yeah, so I kind of found that most of the physicians who have been in practice for a longer amount of time, they kind of had prior experience using decision aids, whether it was a lot of it was through research purposes. So it wasn't like a personal decision to use a decision aid. It was just, their institution kind of had them do it as a part of a research project. So a lot of them had prior experience with the decision aids, but then they've kind of just more adapted to using a style that they have learned works best for them. And I think that's just kind of the difference. And then more of like the younger physicians were more, I guess, like open to trying out different things. And they were just still like learning what, is best for their lifestyle and just how they work with patients.
All right, our next talk is by Max Lukabaugh, and his talk is entitled Burn Injury, Alcohol, and Gut Organoid Gene Expression.
Hey, everyone. Thank you. Good morning. Thanks for joining us. My name is Max Lukabaugh. I'm a second-year medical student, and the talk today is going to be on burn injury, alcohol, and gut organoid gene expression. So just for some background, within the United States, burn injuries are the cause of significant morbidity and mortality. In the United States, there are 1 million burn injuries per year. 40,000 of those require hospitalization, and there are 10,000 deaths annually. So a natural question that comes up is why burn injury and alcohol? Like on the surface, these may seem like unrelated topics. However, interestingly, 50% of burn patients are intoxicated at the time of injury. We know these patients have worse clinical outcomes. It's been shown that the combination of alcohol exposure and burn injury can lead to increased levels of end organ damage and dysfunction. Specifically in the gut, animal models of burn injury and alcohol show increased levels of inflammation and epithelial damage and decreased antimicrobial peptide expression, which are peptides that play a role in the function of the innate immune system. So within the gut, interleukin-22 is known to have a protective role, both in maintaining epithelial integrity as well as regulating immune function. Does this in part by increasing expression of gene products, two of which specifically are reg3 gamma and mucin-1, which is a membrane-bound protein that provides protection and barrier formation to gut epithelial cells. The goal of the study was to determine to what extent, if any, burn injury in conjunction with alcohol exposure affects IL-22's ability to increase expression of both of these gene products. We achieve this by taking black 6 male mice, anesthetizing, shaving, and exposing them to either 12% dorsal area surface burn injury or sham injury. We then flushed, minced, digested the crypt cells, and cultured them to form organoids. For those of you unfamiliar with organoids, you can think of them as 3D cellular structures which take on the properties of the original tissue. So in this case, it was gut epithelial tissue. After 72 hours, we then culture them with ethanol or a vehicle and either expose them to IL-22 or a control vehicle. Then after 24 hours, we ran quantitative real-time PCR. So the PCR data showed that there was no reg3 gamma expression in unstimulated organoids. However, reg3 gamma was expressed in all stimulated organoids. So if you look at the graph on the right, you can see that burn injury alone only resulted in a mild decrease in expression, and ethanol alone did not result in a decrease of expression. However, burn injury in conjunction with ethanol exposure resulted in a 70 or 68% reduction in expression of reg3 gamma. PCR analysis of MUC1 showed only trace expression in unstimulated organoids, and like Reg3 gamma, it was found to be expressed in all stimulated organoids. However, unlike Reg3 gamma, none of the groups showed significant change in the levels of MUC1, including burn injury and the ethanol exposure group. So in summary, we were able to grow organoids successfully and stimulate with IL-22 to induce expression of Reg3 gamma and MUC1. And ethanol exposure resulted in reduced Reg3 gamma in the colons of burn mice, while expressions of MUC1 was unchanged. So what conclusions can we take away from this? Well, one key finding is that the significant decrease in expression of Reg3 gamma following burn injury and ethanol exposure suggests that the combined insult from these factors may alter signal transduction pathways in a way not seen in burn injury or ethanol exposure alone. We can also see that the lack of change in expression of MUC1 shows differences in gene regulation compared to Reg3 gamma. So there were some limitations to this study. One thing we'd like to look at in the future is the effect of in vivo exposure to alcohol as opposed to in vitro. This would more accurately model what burn injury and intoxication would look like in the real world. We also would like to explore expression of other genes responsible for differentiation and maturation of organoids. So yeah, I'd just like to thank my mentors, Dr. Elizabeth Kovacs, Dr. Travis Walrath, and Dr. Rachel McMahon. Without them, none of this would have been possible. Also like to thank the other Kovacs lab members and the Department of Surgery, as well as the Medical Student Research Program ran by Dr. Tevis and Aaron Cox. Okay, sorry, I know that was a ton to get through in not very much time. So if you have any questions, happy to answer them now. Yes.
Great. Do you have a sense of what is that upstream target is? Have you like looked at a barrier issue? Have you looked at some pipe functions yet? Or what's the upstream of the IL-22?
Most likely, I mean, I'm not really sure, but most likely inflammatory response change. I mean, we know like burns can cause a cytokine storm. So you get these circulating high levels of cytokines and damage associated molecular patterns, which cause like immune responses within tissues that weren't affected by the burn. So upstream, probably an immune response that's causing dysfunction. And then you have alcohol exposure, which kind of sets you up for worse dysfunction. Questions?
Great work.
Cool.
It's great that we're getting some basic science, Dr. Kovacs here in the summer program. We haven't had a lot of that. So our last oral presentation is by Jake Reed, and the title is Oncologic Outcomes of Induction Chemotherapy plus Chemoradiation versus Chemoradiation Alone for Esophageal Cancer.
Hi, everyone. As mentioned, my name is Jake Reed, and this is my project. So just to start off with, the preoperative treatment for esophageal cancer has changed drastically in the last few decades. Currently, combination chemoradiation therapy is the standard of care based on high-powered randomized clinical controlled trials. However, further studies continue to evolve and investigate the most beneficial preoperative regimen. Induction chemotherapy before chemoradiation therapy has been touted as a potential alternative to concurrent chemoradiation alone. However, the evidence supporting its benefit is lacking. Therefore, we wanted to ask, does the addition of induction chemotherapy to chemoradiation therapy improve oncological outcomes for resectable esophageal cancer? In order to answer this question, we performed a retrospective cohort study from our own institution, which is a high-volume quaternary referral center, including patients with resectable adenocarcinoma of the esophagus and gastroesophageal junction. Our primary outcome was comparing overall survival in a cohort of patients receiving preoperative induction chemotherapy prior to standard chemoradiation therapy against a cohort that received preoperative chemoradiation therapy alone, the current standard of care. Our secondary outcomes were comparing these two cohorts with regards to recurrence-free survival and pathologic complete response rate. And then after performing a review, we found that 208 patients met inclusion criteria. Of those, 121 underwent neoadjuvant chemoradiation alone, while 87 underwent chemoradiation after induction chemotherapy. The median time to follow-up for the overall cohort was 42 months with no significant difference between the two groups. Our analysis found that both groups were well matched, outside of the induction chemotherapy group being more likely to receive laparoscopic ischemic preconditioning, more likely to have lymphovascular invasion, and on average was more fit based on ECOG scores. Our primary outcome is shown here. Of overall survival demonstrated no significant statistical difference in the cohort of patients receiving preoperative induction chemotherapy prior to standard chemo radiation therapy against the cohort that received preoperative chemoradiation therapy alone, the current standard of care. And then with regards to our secondary outcomes, my apologies, I don't know why the graphs isn't there. They also demonstrated no significant statistical difference between the cohorts with regards to recurrence-free survival and a complete pathological response rate. And then furthermore, we did a preliminary analysis based on subcohorts of stage, location, and the grade of the cancer, and found no significant statistical differences with those as well. So in conclusion, based on this retrospective study, we could not detect a significant benefit of preoperative induction chemotherapy before chemoradiation therapy for resectable esophageal cancer. However, it is important to consider that our study was limited by its retrospective nature. On the other hand, our large sample size and protocol-based therapy at a single institution promoted homogeneity in our strength of study. Therefore, the study indicates further sufficiently powered randomized controlled clinical studies on the efficacy of different styles of preoperative treatment for resectable esophageal cancer, including induction chemotherapy. And the study is potentially practice changing as it may suggest a shift away from induction chemo for resectable esophageal cancer. And then these are the references for the project, and thank yous to those that helped to make it possible. And then any questions?
That your population isn't big enough yet, but I'm not an oncologist, but from my understanding, this is still like surgery, still the mainstay for therapy for this particular cancer. Do you feel that your data, just looking at it in detail, kind of affirms that it's really the surgery in itself is the most important part of the management of this?
Yeah, I would agree. I think the surgery is probably the most definitive and most important part. I think what this was essentially looking at is, obviously with induction chemotherapy for a lot of different cancers, that shrinking down before surgery can sometimes help to improve outcomes. But it seems based on this that it's not really playing a role. And I did read an article briefly that was also looking at like even those that weren't resectable that were a little more metastatic. And it seemed even with those that the induction chemotherapy didn't seem to really be helping. So it'll be interesting in the future. If there's a way we can sort of figure out, like I said, to do like a randomized controlled study to try to figure out if there is any. But yeah, I think right now the best option is still surgery. So. So we didn't do I think that would be a plan for the future, right? We didn't go that far. I know that I had that F.A.C.S was like the most used induction chemotherapy, but there was really only 2 different styles of induction chemotherapy we found. And with regards to like which responded and which didn't, we didn't look at that at this point. Overall, those with regards to within the induction group itself, no, we did not look at that.
All right, we're going to move on to the poster presentations now, so things will move a little bit more quickly. Our first poster presentation is by Catherine Aber with the title Comparison of Preservation Solutions for Preventing Cell Death in Pig Vascularized Myofascial Cutaneous Flaps During Prolonged Cold Storage. Oh, okay.
Hi, everyone. Thank you so much for coming today. So my project was comparing the preservation of cell death for what are known as vascularized composite allografts. And those are pretty much types of transplants that are composed of different types of tissue. For example, with like a whole limb, you'll have bone, you'll have muscle, you'll have skin, nervous tissue as well. Given that they are types of transplants that have more recently become federally regulated, are relatively newer compared to like solid organ transplants. There's not as much information known about the efficacy of different preservation solutions for these vascularized composite allografts. There has been some comparisons in the past of the more common preservation solutions, one being University of Washington or UW, and another one called custodiol. There hasn't been any, direct comparison between those types of preservation solutions to see if one is better than the other for decreasing the amount of cell death for these vascularized composite allografts. Furthermore, something that was done within this lab previously was looking at something that's called necrostatin-1, which is a known inhibitor of necroptosis. And cell lines was found to decrease cell death, but looking at, I guess, on the larger scale of tissue, not sure whether necroptosis or cell death in general can be decreased with necrostatin-1. So that's something we also wanted to look at. So overall, the aim of this study was to look at which combination of preservation solution was most effective at decreasing cell death, specifically apoptosis for our vascularized composite allografts, and see if necrostatin-1 could be a potential additive for preservations to these preservation solutions. So for the methods, we got some abdominal flabs from two different pigs, and they were then preserved with either custodiol, UW, or a combination of custodiol and UW. At 4 degrees Celsius for 72 hours. From there, the tissue samples were then, and I guess the tunnel staining was done on the tissue samples to determine where apoptosis was occurring in the tissue. And then from there, a program called PerioImageScope was used to quantify the amount of tunnel stained nuclei or apoptotic nuclei in the different tissue samples that we had. For the results, first found that between UW and custodiol, although UW was found to be more effective for like solid organ transplants, it didn't appear to be the case for these vascularized composite allografts. And furthermore, it seems that with necrostatin-1, when it was used in combination with UW or custodiol, didn't matter. It was able to decrease the amount of apoptotic nuclei in the tissue samples, whether it was the skin flap or the muscle flap. So it seems that overall, and furthermore, UW and necrostatin-1 combined seem to have the least amount of apoptotic nuclei for the tissue samples. So so at the top, it was supposed to say necrostatin-1 did seem to decrease apoptosis within our tissue samples. So it could indicate that maybe this is a potential additive that could be used for preservation moving forward, but would want to get more data, given that this was just one set of data. Would want to see if this is something that's statistically significant, and then also whether this is something that could be replicated as well with more tissues in different pigs, and would also want to see if maybe then moving forward, if there's some sort of parameters that could be used to for like a whole limb, for example, to see if this is something that we're seeing is increasing the quality of the tissue moving forward as well. All right, thank you.
I have a question. So this was done in 2 pigs, and you said you need more information to better understand how effective this is for tissue preservation. What's your next study, or how will you look at this further?
Yeah, so we do have some tissue slides already that we want to that are been tunnel stains. We want to look at those and then continue to quantify them using this the Perio image scope and see if we're seeing that the sort of with necrostatin 1, first of all, if we're still seeing that in combination with UW, if that seems to be the most effective combination, if necrostatin in general, even with custodiol, is seeming to decrease the amount of apoptosis. And then see if UW or custodiol, if we can see any difference there. So yeah, I guess continue to see with adding more data if we're able to see some of these same results.
Be the same types of flaps.
Yes, yeah, the abdominal flaps from more pics, yeah.
At some point, will you have to look at like pig limbs or to get that bone component and all the other tissues?
Yeah, I think it would be moving forward just to get, I guess, encompass what it would actually be like more like real life and like how replicable we can make it. I think we'd want to move on to whole limbs, but I think maybe starting with maybe rat limbs or something, maybe the smaller animal to see if we're able to replicate that and then maybe move forward into bigger animals from there. Okay. Yeah. Yeah. I think given the complexity of the VCAs and given that there's so many different, there's different types of tissue, and given that maybe not knowing how, if one type of tissue is gonna, I guess, react differently to different preservation solutions than another, I think that we could see that VCAs are maybe a little bit more complex and than solid organs and maybe are reacting differently, is what I think, or vice versa. Yeah. Yeah. I think that could be something that is a potential thing that we could study. Would be good. Great. Thank you. Thank you, guys.
All right, our next presentation is by Chinese Cyrus. Abdominal wall reconstruction with biological mesh is a durable and safe technique in patients undergoing cytoreductive surgery.
All right, thank you all for being here. So this study was on abdominal wall reconstructions, specifically in the patients that have cytoreductive surgery. So for example, if a patient has peritoneal metastases, we would often need to cut out the peritoneum to then get rid of that cancer. And it results in a large defect. So that defect would then be closed with mesh. And then in some instances, patients have hernias even before surgery. So those also need to be closed with mesh. So we wanted to see the complication rates of putting in a biologic mesh in the setting of cytoreductive surgery. So we did a retrospective review and did a pure descriptive study looking at the complication rates. So we had about 44 patients, not necessarily patients, but 44 instances or surgeries that we put in biologic mesh after these surgeries, and found that the 30-day complications of grade 1 to 2 complications were 36%. And then for grade 3 and 4 was 27%. One thing that we found that was interesting with this study was that some of these patients needed high PEC during their operations, and the complication rates were actually lower in those surgeries and for those patients. And the high PEC actually encompassed the majority of these types of surgeries. So so looking at the discussion, when relating this information to the literature, in our study had a larger amount of patients in the study, and the complication rates were actually similar to what the literature is showing. And with the high PEC specifically, it was just interesting to see that the complication rates were lower. So moving forward, some things that we would like to look at would be what intraoperatively, so looking at the amount of anastomoses that were made during the surgeries versus the mesh sizes, and comparing those and seeing if that contributes to different complications.
it a little bit more granular, did it have some sort of CI section and all these types of things?
Yes, so all of the surgeries, they had either they had reduction of their cancer within their abdomen. So it was actually all cancers. So there was GYN cancer, as well as the majority of it was colorectal. And then we had a lot of appendiceal cancers too.
Like you said, you're going to look at number of anastomoses, size of the hernia. Which of those things do you hypothesize are going to have the biggest impact on complication rates in these patients?
Yeah, so that's a great question. At least right now, I think that some of the defects were quite large for these surgeries. So I think size of the defect could be a large contributor. Thanks.
Okay, next we have Lance Desbu. I'm going to screw this up, Lance. I'm sorry. Lance Dubinsky with subclavian artery aneurysm and Marfan syndrome, a clinical dilemma. Was I even close?
Second J.
Dubinsky. Okay.
Hi, I'm Lance Shabinsky, and my project is subclavian artery aneurysms in Marfan syndrome, a clinical dilemma. I worked in a cardiothoracic surgery lab for this project. So just for an introduction, Marfan syndrome is an inherited connective tissue disorder. It's typically autosomal dominant, involving mutation in the FBN1 gene. And the big concern we had with our discussion is that, according to UpToDate, the primary cause of morbidity in Marfan syndrome is aortic root disease that can lead to aneurysmal dilation, as well as aortic regurgitation and dissection. So brief introduction, subclavian artery. For this project, we do focus on the left subclavian artery coming off the aorta for both our patients. And rarely, Marfan syndrome patients can present with peripheral aneurysms. So the subclavian artery aneurysms are particularly rare, representing less than 1% of all peripheral aneurysms, with connective tissue patients accounting for less than 10% of subclavian artery aneurysms. So for us, the picture might be on cutoff, but we discussed a familial case of Marfan syndrome in 2 patients with a history of extensive aortopathy that in turn developed subclavian artery aneurysms. So we discussed the case of a 37-year-old male and his 57-year-old mother. So these results kind of are basically the sequence of everything that occurred with them. There were a lot of complications and a lot of different procedures used. To kind of give you a better picture, and just for time's sake, in the first row, we have patient 1 initial presentation, along with the post-initial coil embolization, as well as the post-open division and bypass. So that would have been the 37-year-old male. And then in row 2, we have his mother and her initial presentation. As you can see, both of them have the complications with the left subclavian artery aneurysm. And then in 2B, we have the post-initial endovascular stenting. And then lastly, we have the post-open thrombectomy and grafting. So you can see a lot of different methods and treatments were used, or procedures were used, to try to repair their issues with the left subclavian artery aneurysms. So in conclusion, Marfan patients with subclavian artery aneurysm present a challenging clinical dilemma. Given their vasculopathy, they are at high risk of rapid expansion of pathology, or require close surveillance and aggressive intervention. And something that we kind of discussed in the lab is that when you do repair one area of the vasculature, it can present problems in the surrounding areas. And again, it kind of leaves you with the whole dilemma of what's next, or how do we monitor them to see if any other complications arise. Okay. Questions?
How did they decide to take each operative approach? Does it seem a little different?
Yeah, and I mean, if you're interested in the whole sequence, I can definitely send that to anyone who's curious. Basically, you look at the surrounding vasculature and what might be best, like if there's any other areas that have show a little bit of signs of aneurysm or are already dilating. We want to see if, maybe a bypass is best or stenting or grafting. We also, I believe it was the male that presented first and then his mother later on. So I think it's all also at the discretion of the cardiothoracic surgeon, Dr. Brett Reese in this case.
What is the recommended surveillance for these patients? Post-surveillance?
I'm not sure on that. I will say something that I did notice and I kind of asked about is that we did notice that the male patient, who's the son, he had a longer, or not longer, but what do you say? He had a smoking history where he smoked a little bit more than his mother. So we noticed that what could have added to like confounding factors. But yeah, I'm not sure on that. Yeah. All right.
Next, we have Noah Keim, of Single Institution Review of Operative Management of Giant Omphalocele.
Thank you. And I apologize. There was supposed to be a couple more pictures, but what can you do? So thank you everyone for the opportunity to present today. Giant omphalocele is an abdominal wall defect, which occurs in about 1 in every 2,500 births. It is defined as giant when it measures greater than 5 centimeters in diameter. And omphalocele happens early in gestation and is associated with other anomalies, including high rates of pulmonary hypoplasia and congenital cardiac disease. There are various ways to close it. One is a staged approach where the infant goes to the OR multiple times for serial abdominal closure and leaves the NICU with their abdomen closed. The risks of this approach are respiratory insufficiency and abdominal compartment syndrome, which are rare but may be devastating. The other approach is to allow the sac to epithelialize and complete primary closure at about 6 to 12 months of age, which is likely safer, but may not be preferred by families. So there are risks and benefits to both procedures, and our aim was to characterize whether the surgical approach, staged or delayed closure, affects short and long-term outcomes. To evaluate our aim, we conducted a retrospective review of children with giant omphalocele at Children's Hospital Colorado over a 13-year period. We included 29 patients, 5 of whom underwent primary repair, meaning their abdominal defect was able to be repaired during the first operation, and 2 infants died prior to final closure. So in our analysis, we included 16 staged and 6 delayed cases. Groups were evenly matched in terms of gender and comorbidities, including 50% having pulmonary hypoplasia, 41% with cardiac anomalies, and 5% with pathology of Contrail. 4 patients required tracheostomy, including 3 in the staged group and 1 in the delayed. When comparing the 2 groups, patients undergoing staged repair were much older at the time of final closure, which was expected. And there was a trend towards more hospital and ventilator days with the staged repair group, but there was no difference in overall mortality or neurodevelopmental outcomes at 5 years of follow-up. And there was a slightly higher rate of ventral hernia repair in the staged group. So in conclusion, based on these data, it appears that patients who underwent staged closure had more hospital and ventilator days, and more ventral hernias. Further work will aim to characterize patient-centered outcomes, specifically family preference of staged versus delayed closure. Thank you.
It's interesting that your second discrepancy between the best afterwards. What do you think are the factors involved with that? Is this because of the red kind of things done in general, or really get
Yeah, I think that it's partly the age and the fact that the closure happens so much sooner in their life. It's usually at like around 2 to 4 weeks of age for the stage group, as opposed to 6 to 12 months, or there were even some infants who didn't have their primary closure until 2 years of age. So I think allowing that sac to epithelialize really helps to provide more strength, and that's kind of the benefit of the delayed repair, is that it provides more strength to the closure.
The long-term outcomes, right, into self-closure.
Yeah, so we didn't look, we didn't specifically identify that. This was over the past, like, starting in 2010. So we didn't look at that specifically, but long-term outcomes, as long as they survive, just in the literature, as long as they survive infancy and they don't die from the comorbidities are the main cause of death in these cases. And as long as they survive into adulthood, really the only primary concern is the cosmesis. So that's when they look at people in adulthood, that's the biggest issue is with how the scar looks just based on the closure. Cool, thank you.
Next, we have Han Lei with pulmonary thromboendarterectomy with moderate hypothermia does not affect neurological outcomes.
Hi there, I'm Amy, and my project is pulmonary thromboendarterectomy with moderate hypothermia does not affect neurological outcomes. So just for some background, chronic thromboembolic pulmonary hypertension, or CTEPH, is a condition that can develop in patients who have pulmonary embolism. And the treatment to this is a surgery where where we can go in and clear the clots from the pulmonary arteries themselves. And this procedure is called pulmonary thromboendarterectomy, or PTE. And during the surgery, what we do is we cool them down to 18 degrees Celsius, or like a deep hypothermia is what we refer to it as. And they also undergo cardiopulmonary bypass as well as circulatory arrest in order for us to get into the pulmonary arteries to remove these clots. And we cool them down to the 18 degrees Celsius, or this deep hypothermia, to protect their organs as they're not getting the perfusion during the surgery. And so we're protecting the major organs as well as the brain. And so our question is aimed at if we cool these patients down to a more moderate hypothermia, so closer to 22 to 28 degrees Celsius, if that's going to have any effect on the neurological outcomes, which was our primary outcome. And so my methods got a little squished, and the arrows are not all going the right way, but we had two groups, so a moderate hypothermia group as well as a deep hypothermia group. They both underwent retrospective chart review where we reviewed their cardiopulmonary bypass time, their mean pulmonary artery pressures, and other variables as well. Both groups also underwent Montreal Cognitive Assessment, or a MOCA, which was a way to assess their cognitive ability before preoperatively and postoperatively. We did it definitively at 2 time points, so preoperatively as well as early postoperatively. And then a third MOCA was administered later postoperatively, so about 2 to 3 weeks after their surgery, if it was indicated. And we found that there were no significant differences between the MOCA scores in patients who underwent moderate hypothermia versus deep hypothermia. And so you can see that in the top graph. And then on the bottom, we have graphs about the pulmonary artery pressure as well as the pulmonary vascular resistance. And we also had no significant differences in those, which led us to conclude that there were, by doing the PTE surgery at a moderate hypothermia, they were not hemodynamically disadvantaged in doing this. And then also on the right, you can see we have a table that has some more of the variables that we looked at postoperatively. I want to point your attention just to the strokes. We had 0 clinically indicated strokes postoperatively. So these were no clinically defined strokes. And so in conclusion, we were able to show that PT can be performed at moderate hypothermia without worsening neurological outcomes, and that the pulmonary hemodynamics improve similarly as in moderate hypothermia as compared to deep hypothermia.
Great stuff to look at. One of the things that I was doing kind of parallel with one of the things that some of the analysis of the papers look at the really interesting to see the
So the reason that I think we started to look at this is because in other aortic surgery literatures, they've proved that, or they've shown that a moderate hypothermia doesn't affect their outcomes as well. And so I think we try to take that and apply that to PTE and see if that could reduce their time on cardiopulmonary bypass and prevent. And so by not cooling them down as much, they spend less time overall. And so just trying to see if that affects their outcome as well.
Next, we have Andrew Meekum with robotic mitral valve repair at Colorado, initial results and comparisons to existing approaches. Sorry, we switched your title, but same topic, right?
Yeah, thanks. All right, hi, everybody. My name's Andrew. My project was mainly looking at a mitral valve repair, which is the definitive treatment for mitral valve regurgitation. It's the most common valvular abnormality worldwide. Roughly 5 in 10,000 people have it. So traditionally, it's been accomplished by conventional sternotomy, which is a big midline incision. You open up the thorax and get a good amount of exposure that way. In the early 2000s, there was a mini thoracotomy, which came around in the second intercostal space. You can open up around 2 to 3 inches. And this was made possible through technological advancements that allowed for enough exposure to address any sort of intraoperative complication in a safe manner. Recently in the 2010s, there's been robotic mitral valve repair, which is also accomplished via mini thoracotomy, but it uses the Da Vinci's eye to gain a unique advantage in terms of the angles of articulation you can get, which are greater than the human wrist, as well as advancements in 3D vision that have allowed for an evaluation of the depth of field despite looking through a computer screen that's remote from the table. So at Colorado, we've mainly had robotic mitral valve repair introduced in 2023. Starting in February, there's a new program that was directed by Dr. Jessica Rove, and this project was mainly looking at the clinical outcomes from that and comparing it to non-robot mini thoracotomy, as well as conventional sternotomy, all at our institution. So all these patients were recruited from 2017 through 2023, and we did some retrospective chart review to look at the outcomes. The primary table to look at would be in the upper right-hand corner. And so you'll notice that the p-values are all listed on the right, and all the preoperative characteristics did not differ significantly. The main outcomes that we were looking at were aortic cross clamp and cardiopulmonary bypass time. Historically, longer times have been correlated with an increased 30-day mortality. And that's been one of the concerns with robotic repair, is that it usually entails an increase in these two times. You can see based on the p-values that there was no significant difference, though on average they were longer. There's also a decreased need for intraoperative transfusion of any blood products. So that would include red blood cells, fresh frozen plasma, platelets, cryoprecipitate. And that was significantly lower in robotic compared to both mini thoracotomy and conventional sternotomy. Rates of new onset atrial fibrillation post-op, so patients who didn't have AFib before the operation and who then had AFib after the operation, were significantly lower in both the robotic and conventional sternotomy cohorts versus mini thoracotomy. The main thing we were also looking at was post-operative length of stay, and this was significantly shorter in robotic compared to mini thoracotomy and conventional sternotomy. You'll see in the middle of the poster that we were kind of tracking the aortic cross clamp and cardiopulmonary bypass times with each increasing case number, and you can see overall, these are decreasing over time. Comparing the first versus the last four, you can see around a 40-minute decrease in bypass time and around a 30-minute decrease in cross-clamp time. So this suggests an optimization of OR and ICU workflow with increasing case number and experience. The echocardiographic outcomes are listed in the bottom left-hand corner, and you can see that across all cohorts, there was no recurrence of mitral regurgitation that was worse than moderate. Both the robotic and the mini thoracotomy cohorts did not have any moderate or worse mitral regurgitation. 3.8% of the conventional sternotomy cohort
did have moderate MR. The limitation with these echocardiographic findings is you can see there's a 40% of the conventional sternotomy cohort did not have any available echo. And the robotic and mini cohorts have really only been tracked in the short and midterm postoperative period. We were mainly getting echoes within the first week or month after the initial surgery, as well as up to 6 months out. So this will have to be addressed down the road to really see how durable these repairs are over the long-term period. So to conclude, robotic mitral valve repair was associated with shorter postoperative length of stay, decreased blood product transfusion in the intraoperative setting, equivalent 30-day mortality, and similar to significantly lower post-op complications, particularly AFib. We're going to need to continue to gather more data because currently there's only been 23 isolated robotic mitral valve repairs throughout the program's existence of this year. And there's around 31 patients in the mini thoracotomy cohort for comparison. So we're probably going to need to get both numbers up to around the 50-60 range to draw some significant conclusions. Thank you.
Do you have any data on opioid use for them or duration of mediastinal drains? And if not, do you have any hypothesis on what that data might look like?
Yeah, I don't think we collected that. We did collect other preoperative variables and intraoperative metrics, but we didn't particularly track opioid use. I don't think it's been tracked in the other existing literature, so that just wasn't something we thought of.
Look at as well as patient-reported outcomes.
Yeah, absolutely. Definitely tracking functional outcomes like pain, limitations of physical activity is something that we're interested in exploring down the road.
That was a nice patient population. So do you have any insight on what enrolled the length of stay, the reduction? Was it the AFib, was it pain control, early ambulation, combination?
Yeah, so the hypothesis is through a smaller incision, you're causing less trauma, in addition to the benefit of the robotic approach being the need for less exposure through retraction. So less damage being caused intraoperatively is the hypothesis to why they're able to heal faster, be able to be discharged faster. In addition, it's also just the ICU workflow being optimized. A lot of the support staff realizing that conventional sternotomy and the way that they treated those patients is different from robotic and minimally invasive repair. You can, over time, those length of stays have been decreasing. So it's adjusting to the new reality of, okay, we're able to discharge them in 4 days now instead of 6 or 7.
Right, but you're not comparing this to sternotomy, right? To mini thoracotomies, or at least sternotomy.
So the CS cohort is conventional sternotomy. Mini is mini thoracotomy. Robotic is mini thoracotomy that also has robot assistance.
Right. But I guess your main, your main comparison in this is the mini, like those are people that are offered the robotic.
Yeah.
Come up with you need 50 each group.
It's just usually what we've seen in terms of the other centers that have done their studies as well. It seems like 23, 31 isn't big enough of a group size to actually draw any meaningful conclusion. For example, the nuance of atrial fibrillation rate, there's a significant difference there, but we're not really sure what's actually driving that between the robotic versus the mini. Perhaps that could normalize with an increased cohort size. So we're getting these artifacts that may not show up with increasing sample size.
You and your mentors probably looked at, well, here's the current standard rate. We want to reduce it by a certain amount.
Yeah, I think that was done by the statisticians who do their wonderful work that I absolutely can't get into. Yeah, absolutely. I think there are definitely some growing pains. The mini thoracotomy that was not robot assisted kind of came about in the 2000s, 2010 era. And we had a much better understanding of the exact operative demands of mini thoracotomy by the time robotic rolled around.
Difference between trace MR and mild MR significantly different between the three groups. And then my second question off of that is the push to do robotic mitral valve repairs to go towards more like advanced MR, or is it to deselect patients with mild MR or trace MR are going to be like the selectable that get off the block?
Yeah, I think robotic MR is currently being used in more otherwise healthy patients because the concern would be the intraoperative exposure for any management of complications. Like you can see the intraop complications were listed in the middle figure. The longest spike in bypass and cross clamp times was with a right atrial injury that was difficult to repair using the robot compared to the conventional sternotomy setting. So it's kind of something that is being driven currently by a healthier patient selection at the moment. But the hope is that over time, as you know, we get to know more about robotic, that eventually these there's going to be more comfort in managing these intraoperative complications. I kind of forgot the first half of your question. What were you getting at?
Was the difference in trace MR and mild MR?
Right. Yeah, so I personally have zero experience interpreting echoes. I was mainly looking at reports for this and talking with Dr. Rove about this. She was saying that the bias from the radiologist in interpreting the echocardiographic report is mainly to see trace MR, where otherwise it would have been graded as no MR if they didn't have the clinical history of some sort of mitral valve repair occurring. So my impression is that no MR is very similar to trace MR, and mild MR is a significant step up from either of those two.
It's just from the numbers, 40%. That's like the p-value.
Yeah, I don't think we actually broke it down by each category. It was more overall moderate or worse versus moderate or better in terms of the analysis that's been conducted so far. Thanks.
Can we have our last poster presentation? Maybe. I don't see it. I'd seen one at the beginning, but maybe I. Give us 1 minute. Hi, sorry about the delay. Our last speaker is Robert Stegman, and the topic is proteomics of acute limb ischemia.
Hi there. Thank you, everyone. So my name's Robert Stegman, and my project is on proteomics of acute limb ischemia. So essentially, acute limb ischemia is a sudden decrease in perfusion to a limb due to either thrombosis or embolism. And so our study aims to compare the proteomic composition of acute limb ischemia blood clots compared to in vitro blood clots from healthy donors. So essentially, we took arterial thromboemboli from acute limb ischemia patients and processed them and saved them. And then likewise, we took in vitro blood clots produced from blood from healthy donors to compare the two. And then we used liquid chromatography mass spectrometry to compare the proteomic composition of the two. And once we had our initial results, we performed a literature review on all of the proteins with increased or decreased abundance between the two to basically categorize them based on their roles in either regulating fibrinolysis, products of red blood cell degradation, complement proteins, and regulators of platelet activation. So in terms of the results, I picked a few groups to present. The first one being regulators of fibrinolysis, where we had 8 proteins, and 4 of those proteins promote fibrinolysis and are essentially clot busters. 4 inhibit fibrinolysis and are considered clot stabilizers. We also looked at complement proteins, where we had increased abundance of the 6 complement proteins, and then for red blood cell degradation, we had increased abundance of 2 proteins, which are essentially scavengers of heme and haptoglobin. And then we had 3 spectrin and ankyrin proteins, which showed decreased abundance compared to in acute limb ischemia compared to in vitro clots. So for the discussion, I'll focus mainly on fibrinolysis, since that's the process at play that really determines if a clot will remain and be essentially durable, or if it can become degraded and go away. So in acute limb ischemia, these patients have pretty tenacious clots, and we kind of have this sense or prediction that fibrinolysis is inhibited because these clots are quite durable. And then when we look at our results, we see that there's a far greater abundance of these clot stabilizers or anti-fibrinolytic proteins, namely mainly vitronectin. It had an over 1,000-fold increase compared to in vitro clots. And vitronectin stabilizes another protein called Pi1. And Pi1 protects clots from lysis. So this massive increase in this protein vitronectin plays a role, a pretty significant role in stabilizing these clots. So in conclusion, we know that coagulation and fibrinolysis are very complex processes with numerous proteins at play. And our results showed that there's a far greater abundance of anti-fibrinolytic proteins, which play roles in stabilizing these clots and preventing them from being lysed. Thank you. Yes, and we didn't look at that specifically. Our sample size was only 12 patients, and so some of them were revascularized within a few hours. Others, it had been more on the time range of days. So we didn't specifically look at that and compare the difference. In the future, once we can run more of these clots through proteomic analysis, we can begin to better we can begin to better analyze the difference between rapid revascularization, meaning clot within a few hours, or those within a few days. I would say abundance of some of these proteins that can potentially have potential pharmacologic targets. Like often thrombolytic drugs like TPA are used in these revascularization procedures. So if we see greater abundance of some of these proteins that TPA acts on, or other lytic agents, then we can kind of better manage, guide medical and surgical management of these patients.
A little bit similarly, do you plan on, probably sample number, but do you plan on separating the thrombotic versus embolic patients?
Yes, yeah, that's a great question. And I think in general for acute limb ischemia, I think upwards of 80% of acute limb ischemia patients have their clots produced from embolic sources versus thrombotic. And right now we did not look at that, I think largely due to the small sample size. And on top of that, some of these patients also did have COVID, which COVID leads to a hypercoagulable state. So it would also be interesting to look at the differences between the COVID and non-COVID clots. So there's a lot of factors that have a lot of room for further research. We just didn't have time to get into that. And I think we would need also a much larger sample size to really see what difference exists. So I'm currently writing a manuscript for this. So we've looked at actually 7 groups total. There's a few I didn't talk about. And I go into a lot more depth on all the different proteins that that have increased or decreased abundance in each of these groups. And then after that, I know there's been previous work that looks at the COVID versus non-COVID clots. So we could go take the project in that direction. And also, if we have the time to just increase the sample size. 12 gives us a good amount of data, but really something a lot more than 12 would be ideal to get significant results. I wasn't a part of the actual proteomics aspect of this project, but so we used the liquid chromatography mass spec, which gave which was able to identify all of the different proteins that are in, I think it's the human Swiss Pro database, which I think has about 20,000 different proteins in it. And using different software, it was able to tell us the abundance of all of the proteins in that database in these clots. Thank you.
All right, that concludes our symposium for this year. I just want to thank Dr. Schulich, who sponsored this program and the symposium every year, and Kathy and Aaron, who've been organizing everything throughout the year for the students. Dr. Christian's helped me co-direct the program, which has been really helpful. And we've had really engaged faculty, mentors, lecturers, and work in progress leaders. And then we had abstract and presentation judges that helped out this year as well. Dr. Nomellini, thank you for being our visiting professor. I think it's going to be a great day with our faculty and students. And then finally, thanks to the students who I know put a lot of hard work into the research projects and gave really great presentations today. I agree with Dr. Schulich that your engagement in research is really moving research forward in the department. So we really appreciate all the hard work that you do. Thanks so much.